It's Mari McInerney from Croaky here today, and we're at the ASMIT conference where we've just had a panel on cancer care for Aboriginal people in the Northern Territory. Des, could you introduce yourself and then Phil?
Yeah. I'm Desmond Mayo. I live at Palmerston and I'm 79 years of age, and I hope to get a thing from the King.
Good. I hope you do too. And you've had your own cancer experience.
Yes. I've had throat cancer, and I got it at the early stages, and treatment was done over 12 months, and it's come out fine.
Fantastic, that's very good to hear. Phil?
My name's Philip Mayo. I also live in Darwin here, and I work at the Alan Walker Cancer Care Centre as one of the Aboriginal Liaison officers. And Uncle Desi is my uncle, and what else we need to mention? That's about it.
Yeah, that's fantastic. Now the panel discussion was really about incidents of cancer amongst Aboriginal people, especially in remote areas, but also about late presentation for treatment and screening, and what are the barriers to that for Aboriginal people. It's a really tough road, isn't it?
It is. If urban, if you live in a city, you're pretty right. But urban, because how do I explain it?
I think just having access to everything. Like Uncle was saying, when you're living in a city, you've got most, access to a lot of things. But when you're remote, it's very difficult because you've got, doctors only attending a certain amount of times of the year. You have one clinic there, and it's usually manned by a nurse, but who's not probably familiar with everything or every other health aspect, just to kind of maintain and the community. But something else you busy.
And urban also, you're still at home, right?
Yeah.
And that's critical?
Yeah. I've got 4 daughters that can care for me, and lost my wife 4 years ago, after 50 years of marriage.
I'm sorry about that.
So they're going to look after them, and they look after me.
And you said that support was really important, yeah?
Yeah.
We've just got the end of another session, so we've got everybody wandering past.
Yeah.
But it was really important to have that support?
It was, yeah.
And did you find the support in the hospital was also good?
I've got no... all I got is good vibes from Alan Walker Centre and the Royal Darwin Hospital. And, they treat you like a human being and help you in any way.
Great. And you talked though about that cancer is a really difficult issue for a lot of Aboriginal people. You said you growing up, you didn't know, you knew about leprosy, not cancer.
Yeah, leprosy was the main thing.
It can be frightening then.
Yeah, when you find out about it, and you've seen what other people have gone through, what other families, and a couple of people who died with cancer, and it's not a good thing
that's right.
to watch, or be part of.
That's right. Thank you. Phil, sorry, we have really got a big background happening here.
Yeah.
For you working in the hospital, what are the big barriers that you see for better care and to keep Aboriginal patients engaged?
I think a big challenge for me is always there's a policy around the patient travel policy. It's really good that the government provides a service to get patients in and out of communities, but there's just some aspects of it that it can't be flexible. And I think when we deal with remote patients and Aboriginal and Torres Strait Islander patients, you've got to understand to be flexible around that. The centre itself is really good at doing that. Like doctors understand if there's a consult missed, they'll no problems with rescheduling and that. But it's just around the probably some of the supportive systems. Like the patient travel's a big one for me.
Can you give an example of what you need to make it work better?
One perfect one is there's a 2-week policy. So if a patient comes in for an appointment, and they have another appointment within the 2 weeks, say it's like 12 days away, that patient can't be flown home, they have to stay in town. The appointment has to be outside this 2 week barrier, and it's tricky, because then this is when we talk about keeping a patient in longer for when we don't have to, so that's always a challenging one, where we've got to, coordinators, work with the coordinators to try, look, can we just push it out one more day, so we adjust for the policy to get people home, to get them with family, get that strength back, then come back in to that re-engagement. Yeah, so that's a really tricky one.
You said a really interesting thing in the discussion, that cancer's not the priority often for patients.
No, and that's just unfortunately, I mean, you're looking at a cohort of people that they're very family centred. So everything revolves around that family and culture. So, as rough as it sounds sometimes, cancer is just another thing to put into the shopping cart, and it's just not seen as, like when you've got, where people, like most people, where their money's coming from, any family commitments they have. So it's like it's working around those sorts of issues to try and get that engagement and get them to understand cancer along the way. It's almost like an educational journey as well. As it stands at the moment, the interpreter service is a good service, but they only have casual staff on at the hospital for like 4 hours of the day, and if it's the morning, it's 8 till 12, and all the doctors' consults, their clinic opens at 1 o'clock. We have to kind of send the request off to get more, and and recently, just coming from a forum, it was mentioned about the interpreters, and there's the government's got so much on hand, like say 20 full-time positions, and there's like 120 casual positions. When I think if they can kind of improve that number, looking at different language group, and also with those interpreters, training them around that health literacy. Unfortunately, there's a bit more focus on the justice side of things and using them for court, and so it'd be good to see more interpreters and get their health literacy up in training, educating them in that area, and talking to patients, and just empowering the patient more to open that communication line.
And what's the message that you give to other people in your community?
Well, I haven't really got a community, because Mum was stolen at a young age, and we brought up in Urban, and we still were under government rule. They used to come around, check your houses, we lived in Sydney William huts with concrete floors, and you still had to do emu bobs. It was a little bit of paper laying around, and you get the old sickle out. If the grass was too long, and cut all that. We're still under that. But, it's really hard, because with cancer, because nobody really knows, eh? No. They reckon it's built in you, and you just need something to... See, being a veteran too, I was sprayed overseas in Vietnam. They used to have the planes come over, dropping off, spraying us, and Agent Orange and that. That's not talked about much now, and you really don't. But I think more education, because people don't know. If you don't get sick, you don't know about it. Yeah.
Well, you said you just had a cough.
Yeah.
To get rid of your
cough.
Yeah.
Started off with a cough, and
but you sought treatment.
Yeah.
Yes.
I sought treatment, and other people won't. It's more of an education. I think NITV's got a bit on cancer with community.
Yeah. And you're on there too, so we'll go and I'll go and look at that.
So it's more promotion, or not promotion, but more awareness. There should be more people go out, and then you got to speak to the elders out there to get permission to go out. That's the other thing.
Yeah. Just knowing that you're coming and talking about something like that.
Yeah. Well, NLC could probably coordinate with it, because they're out there a lot. Yeah.
And Phil, this brings up also cultural safety, which there wasn't really time to talk about in that session, but what role does that have in the decision by a lot of Aboriginal people to not engage with the health system when they have cancer? And also, would you have special messages to the medical radiation sciences about how to do that?
I think, I think the best way is, as I mentioned, just having roles like myself, and within the journey is a must-have, and that kind of supports that, and having interpreters and right from the start, trying to get things right from the start, which they always try to do, but it can be tricky, and having staff trained in cultural safety, but also having it as an ongoing process, not just an annual login, get your cert, you're all cultural safety now. It should be a constantly ongoing thing, because culture is changing with the times, and it's culture's doing its. Let's say culture's probably doing its part to move with times, but are we keeping up? I'm not sure. I don't think we are, because when you've got like 60-70% of participation of patients that come into the hospital are Indigenous, so this is where I come back to. I think where interpreters need to be strengthened, cultural safety courses and awareness needs to be kind of lifted and driven a bit more there. But the environment we work in, I do feel comfortable that, as I mentioned off camera about any time a consult gets to a point where we've seen that consent isn't fully understood, then we say no straight away, shut it down, reschedule, and then go again.
Fantastic. I think you're wanted elsewhere. So is there anything else you'd like to say?
Anything you want to say?
No.
That's good.
Thank you very much. Sorry, Des, you were just going to say?
No, it's just that cultural awareness, and people want to have some sort of cultural awareness before they go into these types of jobs. Even doctors. Because they come from out in the sticks, and first time they see the doctor, some of them, it's got to start out in the community, at their medical centres.
That's great. Thank you very much. Sorry, you're wanted.